All right, everybody. I'm going to talk to you about energy and bones. Let me open up my PowerPoint here. Where we're being recorded. All right. So this is a lecture kind of about relative energy deficiency and just energy in general. Give you an information guide on like how to talk to your patients about energy, food, and all of that. And then there's a couple of questions that showed up in my practice test for the CAQ, and I think I had one on the test, but as Sue's going to test, I kind of blacked out, so I don't really remember the a lot of stuff from the actual test itself. But we'll do a deep dive into energy and then go into relative energy deficiency, history, diagnosis, treatment, and return to play. So, energy and why we care. So, for energy, the requirements, energy balance, energy availability, basically the building blocks or the under part of the giant iceberg of peak performance is adequate nutrition. If you have appropriate energy intake, you'll get optimal performance. You'll also be able to intake all of the important macro and micronutrients. So if you're not getting enough energy, you're actually going to be even absorbing even less of what you take in. And then you can not really manipulate your body composition. So if you're trying to increase muscle, if you don't have enough energy, you won't be able to do that. If you're trying to lose weight, you don't have enough energy, you also won't be able to do that. So it goes both ways. And then energy needs will fluctuate throughout the training period and the competition cycle. So obviously on the off season, you're not going to need as much energy unless you're increasing your training, and vice versa. So kind of the needs of calorie intake will definitely change throughout the season and throughout the off season. There's also things to consider that are outside of the athlete's control, such as exposure to heat or cold. To try and keep temperature regulation will burn up more energy. Fear and stress, so your big playoff games, things like that. High altitude exposure, so when the Browns fly to Denver to play, something to consider. And then physical injuries can actually increase the energy requirements for athletes, both through compensatory mechanisms to try and protect themselves, as well as like the fear and stress that goes along with playing with an injury. Some other influences that can also affect it. So drugs and medications, particularly caffeine and nicotine, which is something to consider if there's a athlete using nicotine pouches. They're going to need more energy because that nicotine is going to be stimulating. Increases in fat-free mass. So the bigger the muscles, the greater need for fuel. So those massive bodybuilders need a heck of a lot of fuel. If you guys have seen like the Rock's diet, it's insane. And then the luteal phase of the menstrual cycle. I was actually talking about this with one of my athletic trainers the other day, where there's an interesting thought that actually increasing caloric intake before starting menses is also going to be helpful. So it looks like there's a lot of fun research coming, so stay tuned. So let's kind of get into the weeds of energy availability and dive into what does energy mean. So let's start with energy balance. This is an easy equation. Intake has to equal expenditure, otherwise you will be out of balance. So your total energy intake has to equal your total energy expenditure, which is broken down into your basic metabolic rate, the thermic effect of food, and the thermic effect of activity. This is great for research, helpful for predominantly sedentary people, just because the basic metabolic rate is usually pretty accurate. The athletes have inaccurate basal metabolic rate, mainly because they don't stay sedentary long enough for it to be accurate. You can use like a resting metabolic rate as a proxy. Doing that though, if you're going to compare sedentary people to like high level athletes, sedentary folks' resting metabolic rate is about 60 to 80% of their energy expenditure, whereas athletes, it can be as little as 38 to 40%. So kind of in the weeds, and then we are going to continue into some more weeds. So energy availability was derived from this energy balance equation, which kind of simplifies things down to a level that is not super helpful for us, particularly clinically. So looking at energy availability, which is a little more helpful for us, is going to be dietary intake minus exercise energy expenditure but we got to normalize it to fat-free mass, because remember, that's going to greatly affect energy availability as compared to the fat mass, because the fat mass doesn't burn any energy. So this will give us the energy available to perform all functions after the cost of exercise is subtracted. So this is just your energy that is available to live and function, and it's not your energy to perform. It was first studied in females in the female athlete triad. Overwhelmingly so over the years, we have found that the energy availability of 45 kilocalories per kilogram per fat-free mass per day was found to be associated with energy balance and optimal health. That was a question on my practice exams, as well as I think the one question I had on the test, it was asking about an athlete, and they had an energy availability of a certain number. The other number to remember is a chronic reduction in energy availability below 30. 30 is the number to remember. Was associated with impairments. So basically, chronically being at 30 kilocalories per kilo is bad. Being at 45 is optimal. So kind of getting into out of the woods and looking at the forest from an overhead view, low energy availability may either occur from decreased total energy intake, so you don't take enough in, or you're burning too much, or for some folks, both. So looking at that and how it relates to the total energy expenditure from the equation we were looking at earlier, basic metabolic rate and the thermic effects of food are not super helpful from a clinical standpoint. When we get like real sciencey with research, helpful, but thermic effect of food is so small it doesn't matter for us, and basic metabolic rate, as we talked about, is problematic for athletes. So we're looking at mainly the thermic effect of activity. So basically, we're looking at total energy intake versus the amount of activity for an energy balance. So in a question stem or patient history, the things to look for is going to be disordered eating, rapid weight loss, and body mass intensive sports. So think of your combat sports, gymnastics, anything that requires someone to look a certain way. So those high level dancers and things like that. And then obviously track and field. An inadvertent failure to meet energy requirements during a period of high volume training. So someone who has like celiac IBS, and they're just not feeling good, so then they don't eat, but then they go train, or people who are sick, viral illnesses, GI stuff, or they're just trying to lose weight because they want to look a certain way. So let's get into something even more relevant. So this is something you can do for an athlete if they're interested, and is very helpful for people who are struggling if they're numbers people. So we have an athlete, they're 60 kilos. We calculate their body fat with calipers, bod pod, however we ended up doing it. You get 20% body fat. So then we need to calculate their fat-free mass, because that's what we need to normalize the equation by. So 80% of their 60 kilos is going to be 48 kilos. And then we look at their energy intake. This can be done by tracking their diet, tracking their food, and then exercise energy expenditure, which is they were doing 500 kilocalories per day. We'll get into how to figure out what exercise energy expenditure is in a little bit. So to find out their energy availability, we subtract their energy intake, which is 2,400, minus their energy expenditure, which is 500, and then we normalize it or divide it by the fat-free mass. That'll give us 39.6 kilocalories per kilogram for fat-free mass per day. So this athlete is not optimal, but they are not in that chronic concerning range. So there's a couple different ways to get energy expenditure numbers from. If you're doing like hardcore research, the ACSM has these codes, and they have codes for literally everything, including like cutting the grass and stuff like that. So you can go crazy with those codes. A more reasonable and practical method would be to use like an Apple Watch or a fitness watch, which can give you a generalized idea of your activity and the amount of calories you burned. Or if you're doing like a targeted energy availability study, you could always do like a stationary bike or something that tries to calculate that for you. Obviously, this is all going to be kind of a guesstimate based on each athlete. So why does any of what I just talked about matter? So low energy availability and performance can significantly impact the athlete, both in the short term and the long term performance, and their long term performance as long as their long term, as well as their long term health. So performance effects, you're going to have decreased endurance, decreased training response. They're going to be working out, and be like, Doc, I just can't hit my PR anymore. I'm actually getting worse. They're going to have decreased coordination, decreased concentration. Their glycogen stores are going to be totally depleted. They're going to have decreased muscle strength. And with all that comes an increased injury risk, impaired judgment, and irritability and depression. And if you look to the health effects, it would start to explain everything in the performance effects. And pretty much every body system is impacted by lack of energy because those cells need energy to turn over and to work. So let's talk about how this relates to bone health and relative energy deficiency. So relative energy deficiency, or female athlete triad, was first identified in 1992. So it's been around for quite some time. We call it a triad because it included disordered eating, menstrual dysfunction, and poor bone mineral density. That was the definition. You had to have all three to have female athlete triad. We expanded it in 2014 because, whoops, it also happens to dudes. There's also a lot of other bad things that we found out happens. It's not just disordered eating, poor bone mineral density, and menstrual dysfunction. There's downstream effects, and those are just kind of the outcomes of those downstream effects. This is the graphic that is in some textbooks still and floating around. On the left was the female side. So the bad triangle is low energy availability with or without an eating disorder. And if you notice, not only do you get functional hypothalamic amenorrhea, so you basically stop getting periods, but you also get osteoporosis. And osteoporosis gets a double whammy because not getting your period also means you're also going to have osteoporosis. If you look over to the right, similar good and bad triangles, but they added some hypogonadotropic hypogonadism to kind of incorporate men as well. Listen to a really great AMSSM talk on this, where they talked about okay, so women have periods and then they lose them. What is the equivalent for men? And turns out it's erections. So no one likes to talk about that, but that's a real problem. And it gets some of the male athletes to think twice about their lack of eating. So here's our new graphic, better than the triangles because it shows the extent of everything that can be affected, which is pretty impressive. And I think is very helpful, especially when talking to athletes and parents of athletes, to say, look, you don't have enough energy availability. Look at all this stuff you screw up. It's also nice, pretty colors. So let's dive into relative energy deficiency. Let's break it down into pieces. So relative energy deficiency, by definition and by the words, would say you don't have enough energy after exercise for the body to function. You have an energy deficiency. It becomes a syndrome because there are a triad of symptoms. So you have low energy availability, you have hypothalamic dysfunction, which then leads to downstream effects of the gonadotropism issues, and then you have low bone mineral density. Again, that magic number is 45 kilocalories per kilo for fat-free mass per day for the optimal energy availability. And the negative health consequences are at 30 kilocalories per kilo for fat-free mass per day and under. Over to the right is kind of a guide, where we're going to go through each of these pieces of the triad to dive in a little bit further. You'll see it on the bottom left of the screen. So first things first, low energy availability. How does it happen? So going back to the deep dive in that equation, so if you don't have enough energy intake, or you have too much of an exercise energy expenditure, or you have an increase in fat-free mass, you're going to lose your energy availability. This can also include abnormal eating habits. So you got your fasting, binge eating, purging. Also, athletes will use diet pills, laxative diuretics, enemas. So that's actually energy expenditure when you're using the diet pills, laxative diuretics, and enemas. So you got to look out for that because that's something that's not considered an exercise that will burn a bunch of energy. And again, thinking about those combat sports with weight classes and any sport or activity that focuses on external appearance. So the effects of low EA, kind of just to address the deeper levels here. So when you have low energy availability, it's going to trigger a physiological adaptation to conserve energy. The only way to do that is reducing cellular maintenance. And when you reduce cellular maintenance, it's going to screw up thermoregulation. You're not going to grow as well. You're not going to have as much cellular turnover. And then obviously a lot of those things, cell turnover is going to affect reproduction. So although the adaptations that are triggered by low EA can help restore an energy balance and enhance survival, we're no longer cavemen, and it's going to impair our overall health. We're no longer running from the saber-toothed tiger. We are just running for sport at this point. So an example, you have an athlete who comes in, they're amenorrheic, but their weight has been normal and continues to be normal every time you see them, despite all of the signs and symptoms of low EA otherwise. And that's just saying that their body is physiologically adapting, but still low on energy. So continuing to dig into this triangle a little bit more, we're going to dive into the functionally hypothalamic. This is a little wordy and gets pretty intimidating, but I'll try and break it down a little bit. So the big effect that we see from low energy availability is going to be the impact on the HPA axis. So to understand that, we got to go into normal bone metabolism and how the axis affects that. Just looking at bone metabolism in general, it's basically a constant tug of war between bone breakdown and bone formation. So you've got bone breakdown and or calcium release and absorption that's regulated by hormones and steroids that can affect how your bones work. Bones we think of as just structural to hold us up, but they actually have a metabolic function of regulating calcium and phosphorus, which is why energy availability can have such a broad impact on bones because of the bone's metabolic impact on calcium homeostasis. So looking at how the bones are regulated, the hormones that we're worried about are PTH, calcitonin, your sex hormones, growth hormones, thyroid hormones, as well as your steroids, vitamin D and glucocorticosteroids that are naturally created by the body. So if we take a look at those regulators of bone metabolism and the HPA axis, you start to realize why low energy availability causes all these downstream effects and causes bone health. So in particular, when your energy availability is low, you're going to have a functional hypothalamic reaction. So your thalamus is not going to function as well. And then if you look at all the downstream effects of your hypothalamus not working very well, your sex hormones and growth hormones, thyroid hormones become dysfunctional, which we know impacts bone metabolism, as well as your steroids. So now we've got a majority of all the things that regulate bone metabolism that are now dysfunctional. But what about PTH, calcitonin, and vitamin D? I'm glad you asked. Bone metabolism, vitamin D, and calcium is also the other piece of this puzzle. So your vitamin D is absorbed by the sun or in your diet, goes to the bloodstream, and then is metabolized in the liver and the kidneys. When we metabolize vitamin D, it allows calcium to be better absorbed in the gut. So not only do you have more availability of calcium, but it's you're able to get more just by the ability to absorb more. And then we also have the negative feedback because once our vitamin D and calcium are good, we want to prevent bone breaking down to add more calcium because we're good. We don't need more because we've already absorbed enough. That was it's a pretty big slide, and it maybe throws you back to med school, which is intimidating and scary. So let's look at this nice little graphic. And this is nice for patients as well because they don't need to know all that extra stuff. So basically, if you have good vitamin D, no deficiency, your intestine's happy, it gets all the calcium it needs, and then your kidneys, are able to help out and metabolize more. And then we don't need to take calcium from the bone to help with our plasma calcium levels. Whereas if you have a vitamin D deficiency, you don't get as much calcium from your intestine, your kidneys aren't helping out very much. Now our plasma calcium is low, so then we go fishing for it from the bone, which causes osteoporosis and bone health issues. All right, so we know about energy. We know why not having enough energy is bad. So what do we do about it? So primary prevention for relative energy deficiency is A, education, and B, screening tools. So those screening tools, there's a ton out. The Leaf and the Lean were kind of the most reasonable. They seem to be most reliable. They actually reflect the note template that we use on the pediatric side when we deal with these athletes, where we're looking at all different types of things. I will click on one of these just to show you kind of what it looks like. Developed in Sweden. And so they basically fill this out, level of athlete. Do you have a job other than just doing your sport? There's VO max testing. There's also like how far they've performed and what level of athlete based on how they've placed. And then all of the information to calculate energy availability, actually. So height, weight, body fat percentage, etc. They also have a bit for food allergies and intolerances, which is important for that absorption at the gut, which we talked about. And then injuries, particularly overuse injuries, gastrointestinal dysfunction, menstrual function and use of contraceptives, and kind of on and on to get to a lot of the things we just talked about. So a great resource. We also have the Lean, which is identified for males. The only difference is instead of menstruation, it talks about sexual dysfunction. And then we have the SM-HAT1, which is the Olympic Committee screening. There's been some debate as to how effective this is, but the Olympic Committee has come out and said, hey, like this is not a diagnostic tool. This is a screening tool. Please use it as such. Over to the right, you will see the kind of the algorithm that they use based on the SM-HAT1 screening tool. So it's pretty extensive. I'm not going to go into too much detail because that alone could be a lecture. There's also a couple other screening tools that we use. The PHQ-9, GAD-7 is another one for mental health issues. So PHQ-9 is depression, and GAD-7 is anxiety. There's also the BADAQ, not externally validated for males, and I think that one is also DSM-4 criteria. And then the Athletic Milieu Direct Questionnaire, which seemed to be the least helpful out of all of these. So limitations, all of these tools were based on DSM-4 criteria and not aligned for the DSM-5. They all pretty much are asking the same thing in different variations, but you need clinical reasoning to make them helpful. So then looking at, we've tried to screen for this, we're trying to treat it, so now we need to diagnose it. Some subjective things you can see when you're looking for relative energy deficiency in your history is going to be their menstrual history, age at first menses. So did they start late? Has this been a recurring problem since before their puberty? Are they currently regular? Are menses currently regular? Any body image issues, aka do you feel the need to lose or gain weight either through yourself or through your coaches? Do you have any food intolerances, special diets, vegan, vegetarian, celiac, etc.? Any history of stress fractures, history of overuse injuries? How much you training? How many miles a week are you doing? Do you have any rest days? The amount of people I see who are like, yeah, I have a rest day. And I'm like, what do you do on your rest day? And they're like, I run 5 miles. I'm like, that is not a rest day. And then any change in performance, you get these athletes who come in and they're like, Doc, I am training more than I ever have in my life, and I cannot get any better. That's kind of a big trigger as well. Looking at sleep, because if you don't recover, you don't improve. Looking at their typical diet as well, 3 meals, a couple snacks, you got to make sure they're getting enough intake, and then hydration and salt intake. So for your diagnoses, you can have some physical exam findings. These are pretty far along. You've flagged red on all of the screening tools and everything looks bad. You're going to be bradycardic. You're going to have orthostatic hypotension. You may even have like discolored hands and feet. And they're like, I think I have Raynaud's, but you're like, no, you just haven't had a period in 12 years. Hypokeratonemia, lanugo hair, and parotid gland enlargement, all kind of things you'll see with kind of the more severe eating disorders. And so then looking from a lab standpoint, things that I usually get: electrolytes, chemistry profile, CBC and diff, sed rate, thyroid function, urinalysis, vitamin D, calcium. There is some debate on getting a reflex to ionized calcium. kind of a debate as to if you're being super accurate and replacing calcium, you should use ionized because that's the true amount of calcium. Like it's a more accurate level of serum calcium, whereas like the actual just regular calcium is not as accurate because you can have a normal calcium from the serum and the ionized can be low, or calcium in the serum can be low and ionized calcium can actually be normal. I think the argument is serum calcium is fine because if that's low, it doesn't really matter what their ionized calcium is. Their stores are low enough that we're worried about their bone health for an athletic population. You also have to rule out causes of functional amenorrhea, which we'll kind of go over, which is, a whole lab set in and of itself, depending on what you're looking for. You can consider testosterone levels and cortisol levels as well, because remember, energy availability will be affected by stress, aka levels of cortisol. So if you already have an issue with cortisol, that could be a problem as well, plus the other adrenal problems that come with cortisol dysfunction. So ruling out other causes of amenorrhea is important. Just because they don't have a period doesn't mean they're not eating enough. So you got to make sure they're not pregnant. You got to look at their LH and FSH. Ovarian failure is going to be diagnosed with an LH to FSH ratio. If they've got a bunch of prolactin and they actually have a secreting tumor that's causing problems with amenorrhea, you can pick that up. Thyroid disease can cause amenorrhea as well. And then there is PCOS. And then androgen secreting tumors and congenital adrenal hyperplasia. So some more fancy labs to look at those, particularly your testosterone is going to be helpful with PCOS. And then hypoestrogenism, you're going to look with their estradiol. Usually at this point, as a provider, I'm passing this on to an OBGYN because that's more of their lane. But these are at least some things you can think of to get as you make that referral to OBGYN. Some other diagnostics that are helpful with relative energy deficiency and secondary amenorrhea. You can do a progesterone challenge test. This if you're out in the sticks, you can't get into OB and you want to be fancy. So medroxyprogesterone acetate, 10 milligrams once daily. They take it for 10 days. If they stop at day 10 and they have rebound bleeding, that's a positive test. And then kind of getting into that is a little out of their scope of this lecture, but something you can read about, but certainly helpful to help diagnose secondary amenorrhea. And then you always want to get an EKG on these athletes. You can get a prolonged QT with low energy availability despite having no electrolyte disturbances. And that's going to be based on conduction, because remember, calcium is a conduction chemical in the heart, or a conduction, I guess, an electrolyte in the heart. So. And then you have bone mineral density testing, which huge wordy slide, apologies ahead of time, but this is kind of a necessary evil, mainly so you can save it, screenshot it, and keep it so you can review it right before you go in and take the test the day before. DEXA scanning indications are testable for the CAQ. So why do you need a DEXA scan? You want to see exactly what their bone health is, and if they already have osteoporosis. How do you indicate that you need that? What is your level of worry? So if you have a high risk triad risk factor 1 or more, that's going to be on the left here, that allows you to get a DEXA scan, or should prompt you to get a DEXA scan. And then over on the right is your moderate risk factors. If you have 2 or more, also an indication that you should be DEXA scanning these individuals. So it's a good slide. I'll leave it up for a couple more seconds just so you guys can make sure you get a screenshot or take a look at it. I'm not going to go into super great detail because this is just memorization of certain criteria. All right, so let's talk about DEXA scans. They're fancy scans that look at bone density, basically. When you look at the bone density, it has different scores that come back with it. So your Z's and your T's. So your Z and T scores are going to be what matters. And it matters which one you use based on your patient population. So your post and perimenopausal women, and you're going to need a T score. For your premenopausal women, you're going to need to use the Z score. Otherwise, it's not going to be accurate, primarily because the premenopausal data and Z scores are matched for age, gender, and ethnicity and population. There's a huge I wouldn't say debate, but there's concern for bias related on Z-scores because we just don't have a ton of data for certain ethnicities, genders, and ages. So something to consider and keep in the back of your mind. But these are pretty accurate, just overall from the people I've talked to and from the lectures I've seen. So your Z-scores, what's abnormal and what's normal. So -2, if you're below that, you're below expected range for age. If you're above -2, that's normal. So 2 is the magic number there. And for some fancy science reasons, it's a negative number. For your bone mineral density, for your T-scores, this is a little bigger of a range. So -1 to -2.5. The 1 to 2.5 is your numbers to remember. -1 or higher, normal. -1 to 2.5, it's not quite 2.5 or more. That's not as bad. So it's osteopenia, kind of that middle ground. And then -2.5, they have osteoporosis. You get DEXA scans you can get it on the spine, usually the lumbar spine, as well as the hips. And then wrist is an option as well. As you can imagine, there's some pitfalls with DEXA scanning because you're scanning for density. As we've known with any of our images, imaging quality can vary significantly. So the DEXA results can also vary upon those different changes in imaging. So the type of scanner can change the results, the technician and how they position the patient, any sort of movement the patient has, and then osteophyte formation and sclerosis from osteoarthritis can elevate your scoring because it looks like the bone's more dense, which technically it is, but that's not healthy density. So for accurate scoring, you always want to use the same location and scanner for the same person. So tough when they live out of state and they got their bone mineral density testing somewhere else. And then using the final report of the lowest score on average of the lumbar spine and the proximal femur. And you want to compare the areas. So actually look at your images for the spine and the hip, because if you just look at the number, but they've got giant osteophytes and you're like, oh, their bone mineral density is good. I don't know why they have all these stress fractures. It might be because your DEXA is inaccurate. If you have individuals who are limited by obesity, or you're more looking at screening an athlete rather than truly testing their bone mineral density, you can use the wrist. It's not very accurate, but it has a high negative predictive value. So helpful, but not accurate. So we've done the screening, they flag positive. We diagnose them with relative energy deficiency with a combination of our physical exam, our history, and our labs, and maybe even a DEXA plus or minus. What do we do? So relative energy deficiency needs a team, a particularly multidisciplinary treatment team, because there's so many aspects to this, because it affects pretty much every body part. So you need a sports med doc, someone who understands the whole process. That's going to be you. Usually a licensed mental health professional, because it's really hard to tell people to eat more. And, there's a lot of information out there that's not accurate. And there's coaches and, other influencers and things that will tell people otherwise. You also need a sports nutritionist, because you can tell people to eat more, but they, as a professional or a high level athlete, their next question is going to be like, well, what do I eat? And a nutritionist will be able to help significantly with their depth of education. The other big thing is teaching athletes about this problem. If they don't know about it, they're not going to understand how to fix it. So you need to talk to them about training volume versus food intake, the importance of fuel and exercise, and talk to them about calcium and vitamin D in their diet, as well as supplements if needed. Definitely need a psychiatrist and psychologist if you've uncovered some eating disorders. And treatment works. There's some studies that showed a 6-month trial in female athletes where if they increase their energy availability to about 40 kilocalories, which is not even the optimal, they resume their menses in 2.5 months, pretty much on average. So increasing their energy availability can completely reverse all the damage they've done. We just need to get there. Obviously, bone health, depending on when we get to them, may not be reversible, but can be slowed down. So let's kind of focus more on how we can increase energy availability. So you can tell an athlete to eat, but if they go and just try and stuff their face, they're going to hate it. It's not going to be sustainable. So this needs to be a gradual increase, typically a 20 to 30% increase over their baseline energy needs. So if you've calculated that, great. You can get definitive numbers, or just by an estimation, 300 to 600 kilocalories per day, increase day by day will be helpful. Relying on the athlete to kind of keep themselves honest for that. Decreasing training volumes is super important. They need at least one rest day, if not more, depending on how severe their relative energy deficiency is. If it's very severe, just straight up holding them back from sport because it's no longer safe. If they have any low bone mineral density, you get a DEXA and it's bad. First things first, you got to optimize their energy availability. Obviously, that's what this whole lecture is about. And then you got to look at their calcium, vitamin D intake. We're in Northeastern Ohio here, so we pretty much all are vitamin D deficient because we just don't get any sun, and or if the sun's out, we're bundled in clothes. So some general recommendations: calcium 1,000 to 1,300 milligrams per day is safe. Your body can really only absorb 500 at a time, so separating that dose out into a morning and night pill gets tricky if they need iron as well, because iron and calcium do not play together well. So taking them at the same time will make them both pretty ineffective. So taking iron and calcium separate. I have multiple athletes who have told me that they're taking a supplement and it has calcium and iron in it. Useless. Vitamin D, 400 to 800 IUs per day is the usual recommendation, but honestly, 2,000 is found to be safe. And is my usual recommendation because it's been found to be safe, and we live up here. It's probably going to be needed, especially if we're worried about relative energy deficiency and bone health. Transdermal estrogen replacement has been shown to improve bone mineral density in amenorrheic athletes. The caveat to this is a secondary amenorrheic problem, not relative energy deficiency that has caused them to be amenorrheic. If they're amenorrheic because they're not getting enough fuel, you will never fix their bone mineral density with an estrogen patch. That's just a fact, because the problem is not estrogen, it's energy availability. So that's a very important caveat to work out with your athletes. Is this secondary amenorrhea and we can fix it with estrogen, or is it your food? So we know that you need to eat more. What do they need to eat? Magic number is 45 kilocalories per kilo per fat-free mass per day. I hope that's the one thing you take away from this. So for protein, especially if you want to have the most optimal amount of protein, it's going to be 1.6 to 2.2 grams per kilo per body weight of day per day. We need those amino acid building blocks to pretty much function, help the body function. Creatine, super interesting. A lot of data out there, not a good consensus. So there's still a lot of studies going out. Basically, we know creatine decreases the rate of bone remodeling. We know that. How much to use is like total crapshoot. And we got to be careful with creatine in athletes, obviously, because of the effect on kidneys, hydration status, and all of that. And if we're not getting enough food, chances are we're probably not getting enough water. So stay tuned on the creatine, but the suspected optimal dose is 3 grams a day. And then vitamin C is actually helpful. It's not just, the emergency, vitamin companies lobbying, but it actually enhances collagen and connective tissue synthesis, which has some downstream effects on bone health. So recommending 5 to 15 milligrams per day. Patient education, that hits hard and is very effective. So peak bone mass and maximum bone mineral density is achieved by age 30. What you have at 30 is what you get, and then you are all downhill from there, quite literally. So whatever you build at that time before age 30 is going to be your peak, and then you can only slow the process down from then on. Your bone mass gains at their peak is going to be between 11 and 14. So even earlier, middle school, when everybody feels super great about how they look, and then 95% of your peak bone mass is acquired by your late teens, because now you're really starting to go through puberty, and you have all those hormones that are able to, affect bone metabolism stronger than before. You do have some small gains from 29 to 20 to 29, you know, but small gains are better than no gains. And then anytime you get pregnant, there's a small decrease in bone density. But with lactation, you get a rapid bone loss. So pregnancy, a little bit of a decrease, but lactation, you get a rapid bone loss over like 3 to 6 months, 3 to 10%, which is pretty impressive. So high risk population. So your pregnant athletes or your athletes who are going to have kids, you want to educate them on this to be aware that those next 6 months are at increased risk for fracture, particularly stress injuries. You do get a recovery of that bone mass over the next 6 to 12 months after lactation has stopped. So it does reverse, but it could take some time. And then if you increase body weight by 5 to 10% has been associated with resumed menstruation. Again, if we're hitting 40 to 45 kilocals, that's going to give us a return to menses 2.5 months, whereas recovery of normal menses can actually take up to a year, which can be very frustrating for athletes. Some books that are helpful: Good for a Girl, Run Fast, Eat Slow, which is a cookbook series, and Secrets of Feeding a Healthy Family. The Secrets for Feeding a Healthy Family was recommended for adults to help with kids and their eating competence. So if you've got a parent who's struggling with this, it's a good option. So lots of good reading material. So let's talk about return to play, right? We've diagnosed this. We got to figure out when they can go back. That's our whole job. So if they're significantly underweight or they have other health issues, sometimes you can do like an athlete contract with specific goals that they need to hit before they can resume activity. It's going to be super variable, right? These athletes, sometimes they'll bounce right back. Other times they've got a huge energy deficit they've got to overcome. So it can take quite some time for them to be safe to play. You should increase energy availability until their menses resume and be maintained while training and competing. Otherwise, they're not out of the woods. Honestly, clearing for full participation, like competition level, I personally would probably want them to have their menses resume before I let the reins off and let them, compete at a high level. But again, this should be an individualized decision because there's such a comprehensive, deficit that low energy availability creates. So we need to make sure they're mentally ready, their bone health is ready, and the athlete themselves is ready. So you need to use that team and the individual athlete included on that to figure out how they can best be helped, what their situation is, and what their risk factors are for falling back into low energy availability. Prolonged monitoring is going to be necessary for those athletes, depending on how severe things were, what the risk factors are for that athlete in their current situation, especially if they want to maintain their optimal health, optimal bone health. That's everything. Went kind of fast, so if you have any questions, now's your time. There's my references.
Sadly, I think I blacked out during my CAQ also. I'm trying to remember. I know I for sure got asked about like which stress fractures were high risk stress fractures. I can't remember if there's anything else. I think that 45 number also came up on my test, not just in my practice questions. But this is really just like a good practical talk. I moved you earlier on the schedule than I was planning because Laura gave the stress fracture talk 2 weeks ago. So I figured I'd try and get them close together in time. So thank you for filling in on short notice.
Of course.
Yeah.
How frequently are you typically having them follow up? Is it about like once a month or more or less often?
Depends on what I'm worried about. So like bunch of stress fractures, reliably trying to like when you talk to the athlete, they're like, when can I go back? When can I go back? And they're like so focused on getting back, and they're just like it's their coping mechanism for mental health, things like that. I have them come back almost every week if it's a training room situation. Not totally reasonable for like a clinic scenario. If I'm thinking like DEXA, bone scan, labs, I usually allow the results of studies to come back for my follow-up. So a good example would be I see the athlete. We have an amenorrheic track athlete who is currently in season. I'm going to need to follow them at least once a week with like touch base, probably a formal eval after the initial when their labs come back. And then, so I'd probably do 2 weeks so we can go over labs and discuss how things are going. Food diaries are super helpful. So doing a food diary. And then during those times, hoping that they've managed to get like a sports nutrition or a, sports psychologist set up. And then I would probably go out another 2 weeks to make sure that the follow-ups that they've set up are active and see how they've progressed. At that point, if we've gone backwards or stalled or plateaued, I'll probably keep 2 weeks. If things are going well, then I will expand it out. Now, if this is like, I've got a stress fracture, what else can I do? We do the labs, we follow up on, phone conversation, and we make sure that things are good, they're healing. And then I just base it on the stress fracture follow-up. If it's even less severe, like I'm not performing to my highest benefit and my menses are normal, then I'm thinking like this is pretty, this isn't nearly as severe. I would probably do an 8-week for that person just to make sure that they've gotten their follow-up, they're have no more questions. And if we need to do like a numbers analysis where we calculate out their energy availability. So I guess too long, didn't listen. It depends.
Who are we referring to for nutrition? Because isn't that a limitation? Like there's not a lot of, I feel like, pediatric nutritionists. Do you have anyone in particular that you've used or?
So there's
I think, yeah.
not a lot of good options within UH, except there is one sports nutrition person, but she's only on the west side, and you can only send patients to her if they're under that ACO plan. And then they get put at the bottom of her list because she's got to take care of people with like diabetes and heart issues and stuff first. So most of us use somebody who's in private practice, who's named Callie Morgenstern, who practices on the east side. But most of the time it's like a cash visit kind of situation for people. But I think she's a good person to start with always. If I think there's like truly disordered eating, I use the Emily program locally for an intake and assessment, and then they usually make recommendations. All right. Anything else before we wrap up for the weekend? Killian, thank you for your time. Everybody have a good weekend. I am headed out of town. I'll be back later on Monday. If anybody needs anything, you're welcome to call or text, but we're headed out probably by lunch today. So everybody have a good one.
Thanks, everybody.
Bye.
Thank you.
Thanks.